Dental Intel, who Steve works for, and most of you know about that company. Phenomenal company. If you haven't heard of it, I would go to and just Google Dental Intel. Basically shows you the matrices of your practice, things that you need to understand and look at every day that you're probably not. Most of you have heard me say this multiple times. I totally changed my software of 35 years because it was not compatible with Dental Intel, because I felt so strongly about that software that we changed to Dentrix just so that we could use Dental Intel. And it's a game changer for us. Second is Utah Valley Dental Lab. Utah Valley Dental Lab is the lab. I'm the director of education, so I have a little bit of bias there, but they do all my work. Any of you that follow me on Facebook or Instagram, all that stuff is Utah Valley Dental Lab, and they generously sponsor half of this with Dental Intel. So they're the reasons we can make this affordable, basically means free, and we can provide the CE as well. So this is now our 19th. First, it was just kind of an idea that I had, people can't go see me lecture. Let's do this fun, real talk, make it casual. We didn't know how long it was going to last, but now we're at a year and a half later and we're having fun with it. And we're going to continue until we don't have fun, which I don't anticipate that happening.
But one thing that does bring me joy and happiness is helping people discover that they have this sleep issues, and they never knew they did. They would talk to their doctors for years. They've had heart conditions, they're on blood pressure medications, yet no one's ever mentioned a sleep study or the possibility of obstructive sleep apnea. And so my biggest message of why I spend my time doing this and traveling the world is to spread the message that sleep apnea is not an old fat man's disease, and that dentists are in the perfect position to help their patients discover it. So even if you don't treat this in your practice, but I'm going to give you today just kind of a backdrop on sleep apnea and why it matters, but also some of that business part of it and how I was able to make it a large part of my practice. I'm still a general dentist. We are very involved with technology. And of course it's not gonna, there we go. This is my family real quick. Now that I have teenage boys, they don't seem to mind me being gone, lecturing and things and playing pickleball whenever I want. This is the only family photo I could get of all of us smiling. So that's my family. And I am a part of 3D Dentist. If you don't know Tarun Agrawal, great mentor, great friend, and I just feel lucky to be part of the family. And so the 3D Dentist umbrella really does focus in on utilizing your technology in your general practice, enhancing the practice that you own as a business owner, and bringing in procedures that you never would have imagined that you could with the help of technology, and going beyond the dental school dentistry. So that's what's really kind of pushed me in the last few years of my career. So I am a partner. I was an associate and then partner of Post Falls Family Dental for the last 19 years. I know I doesn't seem like I could possibly be that old. In Post Falls, Idaho, which is just on the border of Spokane, Washington, and like in between Coeur d'Alene, Idaho, and Spokane, Washington. So we have exploded to the population of 39,000, and our county has exploded from 150,000 to 190,000 in the last couple of years. And some of that is the freedom that we get to live in. A lot of it, actually, I call it, we'll bring in the refugees. And that has really helped our practice too, because the dental IQ is definitely a lot higher. But I discovered that dentists could be a part of sleep in 2009. And I will tell you that I had everything stacked against me, like this doesn't work in practices. And this is 2009, right? So it's still a little bit of the Wild West. And I was like, I am going to make this work. And I created Sleep Better Northwest for a few different reasons. And the first is that there was a dentist retiring, the only one in the area that did it. And the new owner did not want to do sleep. So he pretty much just handed over all his referrals and patients to me. And all these patients were hesitant in coming because they thought they had to leave the dentist they love and transfer to me as a dentist. And so this kind of gives them the freedom to come to me for this specialty, but keep the dentist that they love. And if they don't even know their dentist name, I'm usually like, so Elliott spelled with 2 L's and 2 T's, because I still do dentistry. You can just join our family. But also, it also sets the mindset a little bit that this is a dental solution to a medical problem. And so people get into their mind that dental insurance is going to cover this. No, it's actually medical. And when you go see your medical provider, how much time do you actually spend with the doctor? I know what the people are saying out there. Not very much. And so this is a very team-driven program in my practice. So I am the mascot. I'm there during the consults, and then I'm pretty much not there for the rest of it. The team does the rest. And I am going to go into a little bit more detail on what the team's role is. But that's how I make it work in a general dentist setting, because I'm doing dentistry. And I have basically a separate provider for sleep. And so I think of it as its own business in a way. So we'll go into a little bit more detail on that. But I do want you to know I upgraded my sign. I knew I'd be dangerous with a digital sign of all the fun I could have. And believe me, we do have fun with the sign. And I think it just shows a little bit more of our culture and our practice, more than just, get your wisdom teeth out. But if anyone is interested, please go, and you can even do it right now. You can do it on your smartphone. If you go to joinsleep101.com, all you have to do is enter the email. That's it. But after tonight's lecture and throughout the week, I will be sending you an email with a Dropbox link. And in that Dropbox is the notes from today, as well as some blow ups of some of the things that you might like seeing in here. So you can, and it comes from my email personally. So then you have direct access to me. So here's my partner of 11 years, associate before that. And then Dr. Harness joined us about 3 to 4 years ago. And I'll tell you, she is going to be my future partner. But the beauty of having another tall blonde is that my patients don't know that I'm gone when I'm traveling. So we all work 3 days a week. And even better, I couldn't imagine practicing alone. Even better is that we all kind of have our specialty, our love, and mine's surgery. And, we still do crowns and fillings and in all those typical general dentistry. But I love doing the surgical implants, full arch cases, things like that, where Dr. Harness loves the cosmetic full mouth rehab kind of stuff. And so I do zero endo. So I love that we can kind of split our passions and not have to be the master of everything. And our patients still get taken care of in a great way. I just saw that someone asked for that website again, and I'll have it at the end again. So it's joinsleep101.com. Okay, so this I stole from T-Bone, but isn't it true? Because as we first get out of dental school, it is all about the grind, literally getting our efficiencies up, learning how to treatment plan, learning how to talk with the mouth that's associated with a human being, and just learning efficiencies and grinding it out. But as we get, past that in our career, we start having families, and time is most important. And getting into that advanced dentistry really has allowed me to do more production in 3 days than I ever did in 4. And that is because of the procedural, menu that I bring with implants and ortho and sleep and all those things. But then, of course, you always want to enjoy going to work. I will tell you that there hasn't been a day that I've dreaded going to work. And I think that's a huge blessing for me. And I know there's just a lot of dentists who aren't enjoying dentistry. And so what is it that we can change that would help you to enjoy it? Is it doing more emotional dentistry? I mean, I get hugs for the best buccal pits in the world, but I mean, I get presents and accolades and tears and so many hugs from basically saving their marriage, saving their life, giving them their life back. In the way that we do this in our practice, how we create this environment, create this culture of helping our patients in so many ways, is through the technology that we've invested back into our practice, continuing to learn, and honestly, an amazing team. I'm all about delegating and celebrating the strengths of the team that I do have. So we kind of have, everyone kind of has their little bit of specialty, and I think they find job satisfaction in that too, especially in this environment that we have in dentistry. Our struggle has been the front desk and not necessarily the hygienists and assistants, because we've been able to maintain that. So if that gives you any hope for employee stuff, I hope it does. I think it's going to get better. But when we talk about workflow, you know, I do teach a 2-day course. It's an implementation course. It's like from A to Z, as step by step as you can get, but breaking it down into simple steps, because so often we get asked, what's your favorite appliance? And really, it doesn't matter what appliance you use if you don't have a patient to put it in, because you forgot all these other steps. The treatment part's the easy part. That's dentistry. But learning how to identify this in your patients, learning how to talk to your patients, how to bring it up in a dental setting. You know, back in the day, I used to get like, why are you talking to me about sleep? I don't get that anymore. And I feel like it's because we've gotten the word out that dentists can be part of this. But creating awareness in our patients to lead them to want where they want to see what's going on and get a diagnosis, so that we can talk about the financials, whether it be medical insurance or not, but creating a value where they don't care how much it costs, they just want to get it, creating an urgency. And the sleep study is the way to do that. And then finally, the treatment. So we'll kind of go through all of these steps today, but kind of wrap it up with, what do we do when it's not working in our practice, and how can we overcome some of these hurdles? So I'm going to kind of start with what sleep apnea is and why we care. So sleep-related breathing disorders kind of covers a whole continuum of apnea. So primary snoring means that they've been tested and all they do is snore. I will tell you that it is rare just to have that. And then continuing on, there's something called upper airway resistance syndrome. And this is where my passion lies, is in these patients, because they get overlooked so often, because their body is the young, fit female TMD type patient where they're exhausted, light sleepers, insomnia, wake up at 1 a.m. and 3 a.m., maybe not sleepy, but exhausted. And they chalk it up to young kids, stress. This is how I've always slept. But in reality, it's actually a sleep-related breathing disorder. Their body, their airway wants to collapse. They're usually thinner, so their airway's thinner, but their body just keeps them awake or in that light stage of sleep to prevent them from that airway actually collapsing. So that fight or flight is all night long. That cortisol release is all night long, and they tend to be a little bit more anxious. And then along with that TMD, there's no pain inhibition occurring in the deep sleep. So they're just running on fumes. And if they were to get a sleep study, they wouldn't test as apneic. So then they would be told that they're fine. So this is where I think dentists shine, is helping these overlooked people, especially since it oftentimes involves TMD. And then there's obstructive sleep apnea. That's the one we care about. That's the one we treat. And then central sleep apnea is a rare type, but basically the brain doesn't tell the body to breathe. So that's something that we don't really treat in our practice with appliances. But obviously we like to see normal breathing, oxygen going to the vital organs and brain while we sleep. But an obstructive sleep apneic event is essentially usually where the tongue and soft palate collapse. And so it closes off the airway, and the person is trying to breathe, but the airway is physically blocked, and until their body kicks in that fight or flight to get them breathing again. They can turn over, they can grind or clench their teeth to open their airway, or they might fully awaken or wake up gasping and choking. So there's so many different symptoms. And my favorite part of doing sleep is the detective work, is connecting the dots for patients so that they see that this is actually impacting their life. Here's just a better view of seeing how large that tongue really is and seeing the collapse against the back of the airway. This patient's actually sleeping. It's an MRI. And, of course, the patients think the tongue is this big, but us dentists know that the tongue is, you can see how large it is there. So if you are prepping 15 and you're afraid of cutting the tongue, or for the hygienists out there, if you're scaling the distal 15 and the tongue's pushing your scaler out of the way, might be a sleep apneic tongue. That's all I'm saying. But it kind of creates a bad cycle. So as we go to sleep and our airway narrows, we start to snore. Snoring is just a sign of a narrowing of the airway. It's vibration of soft tissue. Not everyone who has sleep apnea snores, but that tends to be one of the biggest motivators for patients to come in, is to get their wife to stop nagging them. And then when that airway narrows to the point of collapse, that's what's called an apnea. So our oxygen goes down and our CO2 levels go up, and our body shoots out adrenaline or cortisol to activate those airway muscles again, and the breathing resumes, we relax, and it just happens over and over again. And we're staring in the mouths of these people suffering over and over again all day. So I'm going to kind of go over how to identify those people. But just some quick definitions here. When we do a sleep study, we're measuring airflow. We want to see how often that airway closes down, for how long, and in what position. Basically, how many times an hour this happens. So a hypopnea, hypo means less than. I don't know if you know this or not, but I'm a major nerd and I took Latin in college, but a hypo means less than. So essentially what this is saying is it's less air. So if you can imagine, your airway is not wide open, you're breathing through a little straw instead of a nice wide open airway. So you can see in that top line, that's the brain waves. That second line is the airflow. And you can see that it's really kind of diminished. And then the rest of those lines are the effort, or the effort belt. The patient, in order to be obstructive sleep apnea, is still making an effort to breathe. It's just that the airway is physically blocked. And so at the top there, you'll see an arousal of the brain waves. So that's the brain's way of taking you from a deeper stage to a lighter stage of sleep. May not fully awaken you, but it's enough to interrupt the deep restful sleep and the REM sleep that our body needs. And hence why you don't remember your dreams, maybe. A lot of people think that's normal to not remember dreams, or to the point where you just never feel rested. Deep sleep is where our blood sugars are regulated, good hormones are released, and bad hormones are cleaned out. And so if you're never reaching that deep sleep, then you're never fully catching up on the health that you deserve. So a hypopnea is a partial closing of the airway, but so much closed that your body, your oxygen goes down and your body creates an arousal. And then there's an obstructive sleep apnea, and that is where apnea means without air. It's a complete closure of your airway. So again, you can see the brainwave, the airflow is flatlined, the patient's trying to breathe, but just can't. And then finally, the brain creates an arousal, And you can see kind of the up and down lines of that effort belt. And that's because the patient's having rescue breaths. So this is kind of the analogy I use, that snoring shows some turbulence in the airway. A hypopnea is just like a little trickle of air, but just not enough. And an apnea is when the faucet's fully turned off. And so in a sleep study, they count all of these and add them together and divide by the number of hours slept. So we have what's called an AHI, apnea hypopnea index. It's a very faulted system. In fact, when it was created, it was never meant to be the Bible. It was just a starting point of trying to quantify the severity of sleep apnea. And unfortunately, medical insurance and medical doctors were like so locked into this. But there's been some movements to move beyond this. But so far, medical insurance sticks to this like no other. So basically, if you're in the mild to moderate range, you can have an oral appliance as first-line therapy without having to try CPAP. Anything over 30 is considered severe, and so you need to show CPAP intolerance or a medical contraindication to CPAP if you want medical insurance to cover this. And then they say anything under 5 is normal. Well, there's the problem with the upper airway resistance people. If you are a 4.5 and waking up constantly throughout the night because your body would rather wake you up than have your airway collapse, then you're told that you're normal and you continue on life exhausted and feeling like you're crazy. And so we capture a lot of these people. We help them still with appliances. It's just that medical insurance doesn't cover it. And it's like we finally we do the work, or the appliance does the work, so the patient can finally rest. And that's been one of my greatest whys, is helping people that otherwise would have been ignored for many years. And so why should we care? Because it's common. And oftentimes the first question I get too is which physicians, doctor, or where should I get my referrals? Should I go talk to the sleep physicians? Do I talk to ENTs? What I say is you start within your own practice. You need to have a workflow that works so you know what you're doing before you receive a patient from outside your four walls. Work on your team, their spouses, their bed partners, family members. Get the workflow down so then the patients go back with good reports of you know what you're doing. But they say that it's 1 in 4 men and 1 in 10 women that have sleep apnea. And that number actually becomes equal between men and women in menopausal age. And that is because progesterone actually helps keep our airway open. It's an airway dilator. And in menopause, what happens to progesterone? Also in menopause, one of the main complaints we get from women is insomnia. And so they chalk it up to menopause when really a sleep-related breathing disorder is actually popping up. And so if you kind of have chronic insomnia, they're finding, the Mayo Clinic even did a study that 91% of those people actually have obstructive sleep apnea, a sleep disorder, not just a menopause problem. And as we get older, our muscles tend to sag, hate to say it. Our soft palate continues to grow and we kind of lose muscle tone. And so the older population, we see an increase to 50% of the population. The problem is that 80 to 90% of those patients remain undiagnosed because it's still an old fat man's disease to too many medical professionals. And so what I've kind of learned over the last 13 years of treating sleep is educating those people, but also just kind of taking matters into our own hands. And I'll kind of show you what I mean by that. What is the saying? Well-behaved women rarely make history. Of those patients that have been diagnosed, that they were tired enough to admit they had a problem, tired enough to go to the doctor to seek help, tired enough to get tested, tired enough to go get the CPAP, how many of them are actually wearing the CPAP that was given to them? And I'd say 60% on a good day. And so there's a ton of those patients in your practice too that gave up on the CPAP. But the issue is they were never given another choice. They were never given another option. And right now, there's a huge controversy in the sleep world because Philips had to recall about 3 million machines. And so what they told their patients is to essentially go without, not go look for alternative treatments. It's crazy to me. But
hey, Erin,
okay,
can I interrupt you here? So, you said that the heavyweight old man's disease that we used to think it was. Are you going to talk about factors or pre-existing conditions that'll lead to this? And do you find some of these patients that are apnea patients that if they lose weight or they change lifestyles, that they basically can cure themselves? And the only reason I say this, I used to have, and I know you're a pet person, I used to have a yellow lab that whenever she would get above 67 pounds, she snore. And I'm a light sleeper. I'm like in that category of thin and waking up all night and watching the clock going, right? So I couldn't sleep because she would snore. And if I could get her down to under 65, she never snored. And do you see that in your practice?
I do.
mean, is some of the recommendation, as a dentist, you need appliance, you need sleep study, but you need to change your lifestyle a little bit?
Yeah, and so we do have to be more than one hit wonders. Like we can't just be about appliances. So that's why I think it's important to learn about all the options and things to use in conjunction. So they say for every 10% of your body weight you lose, you can lower your AHI by 30%. So it does have a big impact. And a lot of that is because you can gain and lose weight in your tongue. Some of it is where do you hold your weight? So I think it's like the chicken or the egg. Are you overweight because you have sleep apnea? Or do you have sleep apnea because you're overweight? I think it starts out as an anatomical, physiological issue. And when you feel like crap and you're not treating it, you choose, it's proven, you choose higher carbohydrate foods because your body needs quick energy. It's depleted. There's two main hormones called leptin and ghrelin that are released during deep sleep. Ghrelin tells us when we're hungry and leptin tells us when we're full. Those get out of whack. Deep sleep is where our blood sugars regulate. And so it's easy to gain weight and the severity of the sleep apnea goes up. And if you lose weight, the severity can go down. Now, does it go away completely and cure it? Probably not, but the severity goes down and the appliance works better. So yes, I have that conversation quite often. And of course they look at me and they're like, well, it's easy for you to say, not saying I'm perfect, but I lost 30 pounds and, kept it off for 5 years. So it's not like I haven't been there with them. And what I say to them is like, I don't want you to lose 50 pounds. I want you to lose 5 pounds.
Right.
Like this appliance is going to get you feeling better. Let's just start with small steps.
But lifestyle conversations are part of your whole deal. Yeah, good. And I think dentists struggle with that a little bit.
Yeah, I mean it's hard when I know it's a touchy subject, but I do think I have the advantage of talking woman to woman sometimes, and even with men, I feel like I can be like, come on, bro, let's lose some weight here. I feel like I have that kind of relationship with them, right. But not the easiest conversation to have, but that's all part of it. Yeah. And I deal with very stubborn Idaho men. I will tell you that. So for them to even come in the door is kind of a big deal. So I am very gracious. So basically, how do I identify these patients? Like it plagues me now because I'll be at an airport and I'll be, picking out sleep apneics. It's a terrible problem now. But how do we create awareness and identify this? And we can start before your patients even come in Monday morning. I bet you could identify a handful. Patients that have had previous strokes, maybe they haven't had a stroke yet, but you're 90% of nocturnal strokes are actually preceded by sleep apnea. And of course, it creates a huge stress on the heart. I didn't show you the video of someone having an apneic event, but you can see the struggle they're having. You can see that increase in stress. And the stress on the heart would include hypertension. Do you have any patients with hypertension or on more than one drug for hypertension? And I always love when I ask patients, do you have high blood pressure? And they're like, oh, no. I'm like, oh, it shows here you're on 2 drugs for it. And they're like, oh, yeah, but that's why I don't have high blood pressure. So hypertension is the word I use. Coronary artery disease, cardiac arrhythmias, actually AFib is a huge one right now, where cardiologists tend to be reactive, not proactive. But once someone gets diagnosed with AFib, they are on their butt to get a sleep study and get treatment. And an oral appliance just happens to be a treatment that works. And if you do treat someone with AFib with an appliance, the incidence of AFib goes down. And so they just did a study. It was about 1,000 patients of AFib patients, regardless of their sleep symptoms. If they said they slept like a baby, they still had to take a sleep test. And 84% of them had sleep apnea. So that's how big it is in that kind of AFib world. Congestive heart failure, heart disease. Do you have patients that are taking a baby aspirin because they're concerned about their heart? People with untreated sleep apneics use twice the healthcare dollars. They're just not as healthy. Do they have poor sleep, which affects mood, depression, anxiety, loss of motivation, daytime sleepiness, car accidents, then the loud snoring that can create relationship discord and sleeping in separate rooms. I treated a marriage counselor once and she goes, oh my gosh, I need to send my patients in here, my clients that are sleeping in separate rooms, because they miss so much of that intimacy before bed and sharing what sharing a bed comes with. But I see some annoyed wives and the husbands that say, I don't have the problem, she has the problem. And so I think sometimes I get thank yous more from the spouses and their insomnia cured as well. Diabetes type 2, again, blood sugars are regulated in deep sleep, and oxygen deprivation does have a role in glucose intolerance and insulin resistance, as well as the cortisol as well. And then, of course, obesity, we kind of talked about that. Like, I say it's an anatomical and physiological disease, meaning that you could have a small arch and a large tongue. So there's nowhere for that tongue to go but back. But you could also have an airway that's just collapsible. McDonald's straws are nice and wide, but they collapse. And then you have straws like those coffee stirrer straws that are skinnier, but they're solid. And so I don't think it's just anatomical. But once you have those kind of stacked against you, it's easy to gain the weight and hard to lose it. And the severity of the apnea goes up. GERD or acid reflux, 66% of those suffering from GERD or acid reflux symptoms have sleep apnea. And it's because it creates this, when you're trying to breathe, but your airway's blocked, it creates almost a vacuum effect. So of course we can see the erosion in the teeth, but a lot of people deny sleep or deny acid reflux, even though we see the erosion. And so I always ask about other symptoms, the atypical symptoms, not just heartburn, but people that clear their throat a lot, people that have like a hoarse voice in the morning or a non-productive cough. All of those are signs of acid reflux, or postnasal drip, like 12 months out of the year. So those are things that I look for and ask further questions. And then ED, We don't talk about that with our patients, but oxygen at night and ED go hand in hand. And a lot of those medications that we hear about on every other commercial for the NFL, so it must be a common problem, works on nitric oxide breakdown. And if we could just give our patients oxygen, then they don't maybe need the help. And then lastly, Nocturia. This is my favorite one. Not my favorite one, but when we bring a patient in for a consult and start the conversation and bring out all of these other things that they thought had no relation to sleep apnea, it creates that much more value. What I mean is, if they get up to use the restroom several times a night, oftentimes they blame it on, I have a weak bladder, I have a bad prostate. Isn't that part of getting older? It's my dog that woke me up. But interestingly, in a sleep study, just before a patient wakes up, I can see a whole string of apneas. And they think it's because they have to use the restroom. But really, it's the sleep apnea. And once that's treated, it's amazing how they sleep almost through the whole night, unless they have the snoring dog. And I know I said 1 a.m. and 3 a.m. are kind of the keys there for me with people with insomnia. And the reason why I say that is because that's when REM sleep is at its highest. That's when it's at its most. And in REM sleep, our body's paralyzed. Otherwise, we'd act out our dreams. So in REM sleep, our airway is at its most compromised. We're not breathing as deeply because our intercostal muscles don't work. Our airway is at its most collapsible, and we can't turn over. We can't kick our leg. We can't clench or grind our teeth to open our airway. So our airway is at its most compromised. It collapses, and our body would rather wake us up than go without oxygen. So that's why those are those key times. And when I say that, it's people are like, oh my God, are you like in my bedroom with me? It's like I can predict it, you know. I've done this a time or two. So I just want to share just a patient of mine that is pretty typical. So he's on, it says medicine, dosage frequency, and the reason why. So he's on Micardis because of high blood pressure, metformin because he's pre-diabetic, baby aspirin for his heart, Protomax for acid reflux. That's like check, check, check. And probably like a lot of your patients. But what he also added is that he's on Viagra twice a month if he's lucky, but mostly just once a month. And you can see the reason why he takes it. Just thought I'd share that with you because most of the time, like I said, patients don't share that with me, but thought it was funny. So before your patients come in Monday morning, did they mark any of these? Are you looking ahead for your candidate of the day? You do not need to talk to anybody and everybody. In fact, in order to avoid the overwhelm of your hygiene team, which is really where this starts, we tell them to just bring it up and we'll put the stamp on. Our goal is to get the patients to get a consult. So how many hygienists will not bring it up if your doctor goes into a 15-minute lecture or education? Whenever I hear, oh, I educate my patients, I'm like, what that means to me is that you do the talking and the patient does the zoning out. And your hygienist does the, hey, I need my op. And so we kind of bring up the basics. Hey, this is what I'm noticing. I noticed that you have hypertension and I'm noticing the scalloped tongue. I would love to get you back for a consult so we can talk about how we can help you with how you sleep. Do you wake up refreshed? Has anyone ever told you snore? Forget the question, do you snore? Never ask it because you'll never get an honest answer. Has anyone ever told you snore? I have fibromyalgia on there. There, more and more links to that because that's inflammation. Cortisol leads to inflammation. Periodontal disease is related to obstructive sleep apnea. So all of these things our patients might have kind of come back to that foundational core of how we sleep. If they tell you medications or take out their list, there's this awesome website. So if you're at home and you want to write this down, it's www.google.com, and it'll tell you exactly what medications they're taking and why. And you can kind of lead that back to a conversation. So in that hygiene discussion, there's three main objections that patients have of why they're like, stop talking to me. They think sleep apnea is an old fat man disease. So oftentimes I even avoid that term. But what we bring up is that you don't have to go spend the night somewhere weird to get tested. We have home sleep test options. The second is that you won't be stuck with that mask. You might be a candidate for an oral appliance. And here's some examples. And once they see them, especially the ones I'll show you that I use, they're not bulky, they're quality made, they last 3 years or more. And so it doesn't seem as scary for patients. And then lastly, we tell them that we bill medical insurance. Now, I'm going to actually not suggest that right away, because that's where most offices get stuck. So that's coming up in our financial section. So we can look at their health history. It gives us a lot of clues before they even walk in. You can change your health history. I actually don't use a lot of questionnaires in the new patient questionnaires. To me, it's about a conversation. It's about seeing these things, starting a conversation and getting the patient to talk about their pain points. What would motivate them? And you're not going to win them all. Sometimes you're just planting seeds, and sometimes it's years later they come back and they're like, remember when you were telling me? And usually it's because they got a girlfriend or something in their life changed. Their granddaughter made fun of them because they had to share a hotel room. There's always I always love the why now question. So when we change our health history, we asked, have you been told you snore? Have you been diagnosed with sleep apnea at any point in your life? Do you wear a CPAP, or have you in the past or been told to? Those are all three different questions, because some people, they just won't even listen to their doctor if they think that the CPAP's the only option. Like my dad said, he was one of my first patients. He goes, I would rather live in ignorance than do nothing about a problem that I knew that I had. So he avoided a sleep test for a long time, knowing he probably had a problem. And so if we make that entry point easy and not scary, more patients are willing to get help. And then, have you had a sleep study or been told to get one? So a lot of times patients tell me, yeah, I had a sleep study, it said I was fine. So my very first question is when? And if they say 10 years ago, I'm a little bit of a smart aleck. And so I'll get, oh my gosh, yeah, I got my eyes checked when I was 16 and they told me I had 20/20 vision. So I haven't had to go back. Things change over time. So just because 10 years ago said you didn't have a problem, that doesn't mean you don't now. And I would love to see if there's something going on now. And then sometimes they were given a sleep study. They think it was a sleep study, but instead it was a pulse ox. And all that does is measure pulse and oxygen. It does not measure airflow. So we get a lot of false negatives of people that think they're fine when really they're suffering.
Can I interrupt you here? Can I interrupt you?
Please.
Erin? So when you're talking about medications, is a red flag someone who's saying that, yeah, I take Ambien 2 or 3 times a week, or I take melatonin because it's the only way I can sleep?
Yep, absolutely. And that's why I added these to the little squares at the bottom. A lot of them say the same thing, insomnia and trouble sleeping, but sometimes patients hear it differently, right? They're like, oh, well, I don't technically have insomnia, but I have trouble sleeping. So I put all of these kind of in that upper left corner because they're all related back to sleep apnea. So if they mark yes in any of these, then it's a patient that we're going to have a conversation with. It's a patient that we're going to say, hey, here's my candidate of the day in the morning huddle. We're going to identify these patients. Probably the ones that are on a whole bunch of medications is a great place to start. But we have there's so many different types of sleep apneics with different symptoms, the insomnia ones, the overweight, severe fat guys that say they sleep like babies, and then the young TMD that sleep like crap. And so we have this whole range of symptoms and types of patients. And I just love that we get to connect the dots for them and become their advocate for them through this. And so we have subliminal marketing up in our practice. I really should probably get rid of the alarm clock graphic, but a lot of people dread the alarm clocks. So I thought that was good, but no one uses them anymore. I just found out today that you can spend up to 3.5 months of your life pressing the snooze button if you're a snooze button pusher. But notice
that's the best 9 minutes of sleep. I don't know whoever invented them.
I know I wish they had 5 minutes.
How come they're all 9 minutes? I just don't even
I know.
Even the phone,
need to change that.
9 minutes. But where'd that come from?
I'm still trying to figure out how to change that. Yeah, I don't know the 9-minute one, just enough to get back into deep sleep. So ask your hygienist today for more information, because I feel like that's where that's where they have the time. And the dentist should not start a 15-minute conversation on sleep. I basically address the 3 things of, hey, let's bring you back for a consult so we can talk more about how this applies to you and how we can help you. And we can set you up for a sleep test that you do at home and not have to go somewhere weird and have someone watch you sleep. And you take away those hurdles, they can't help but say yes. And we bill medical, not dental. Now, I created this kind of as our dental signs and symptoms. Again, this is an overview, and I can go into much more detail, but some of these say the same things too. Class 2 and retrognathic are obviously the same thing, but if we just were to focus on bruxers in acid erosion patients and scallop tongue patients, that is so many. Those are like the main signs for me for sleep apnea. Bruxing, I think I show you a visual of how it actually opens up the airway subconsciously. Acid erosion, we talked about that. We can see it in the teeth and in how a huge percentage of acid reflux sufferers are sleep apneics. And then a scalloped tongue. You're going to see these everywhere now. So before I have a patient lean back, I actually just have them simply open and then not stick out their tongue, because once they stick out the tongue, the scalloping kind of goes away. But it's essentially these little indentations on the sides of the tongue. And what that tells me is that there's not enough room for the tongue they have. I never say that you have a large tongue. People take offense to that for some reason. So I say you just don't have enough room for the tongue that you have. So it's been pressed up against your teeth, trying to maintain an airway and taking on the indentations of the teeth. And then lastly, just what does their airway look like? Is it swollen? Do you have a battered uvula? Is it narrow, small? These are things that we're all looking at. And hopefully we can take pictures of to show them. So I added these at the last second because you gave me permission, Dr. Hornbrook. But I just wanted to share a funky idea I had, and I'm not afraid of making fun of myself. So I figured I could spread the word about sleep apnea in a fun way.
Now, this is a story all about how I can help you sleep without a sound. I'd like to take a minute, just sit right there. I'll tell you about how I became the queen of good air. In sunny California, born and raised, Post Falls is where I now spend my day. Chilling out, drilling, relaxing, all cool. You using Mr. Thirsty to suck up the drool. When a couple of stores, they were up to no good. started making noise in my neighborhood. I said, let's fix that snore, but my team got scared. But to help sleep apnea, we have to get prepared. We scanned lots of teams day after day and knew we were finally on our way. If you're having trouble sleeping at night, waking up groggy in the morning light, causing your partner to complain about the noise, we can help your problem. Have no fear. A simple appliance will make things clear. I looked at my practice. I was finally there to sit on my throne as the queen of good air.
That's cute.
So there you go. But don't worry, I am not a one-hit wonder. There might be another one coming up.
So where'd you put that? Did you put that out in the community, or is that just fun for your patients?
Yeah, it's perfect for patients in our town. We're still kind of a small town as much as we're growing. And of course, lectures and things like this. So I think it's a fun way to get the word out that dentists can help. But I think a big thing here is that it's very tempting to not go through all of this red tape and have to do a sleep study and all of these things and just make the patient an appliance. And I will tell you that as much as I live in the gray and do what I can to help patients get the help they need, there's a few absolutes that I work with. And one of them is that absolutely the patient has to have a sleep study first. I've been tricked too many times where I'm like, oh, there's no way you have sleep apnea, and they're severe. And so we would have been putting a Band-Aid on a more severe problem. And then there's people that it just tells so much of their story, like I said, than just making a night guard type thing and charging, I don't know, whatever. I've heard, oh, double the night guard fee, $800, here you go. And not really not knowing about their sleep disorder, if they're treated properly. So it's kind of like, I don't do any endo, but I would at least start with a PA. And that's how I kind of feel about sleep apnea. I always start with a sleep study. And if a patient, oh man, I just want to apologize. I think it's because I'm using a new spot and the Wi-Fi seems to be working now. So I am sorry to mess that mojo. I did see that the joinsleep101.com is working. It's just, you just put your email address and first and last name. Someone said that wasn't working. Also, the take-home sleep test, we can get into this again. I do own Metabyte Junior made by Braybon and WatchPat Pros. I did see a few New Jersey and Georgia people chime in. My solution for you, because they're the two states that actually have it written in the state board. It's not just an opinion, where a lot of states have just opinions. So it kind of depends on your comfort level of owning home sleep tests, but getting the patient to the sleep test is the key. That's where the magic happens. That's where the ownership happens. It's where they come in dragging their feet and saying, I don't really want to be here, to holy crap, I better get this. And I do use several companies to help me along the way. And so kind of the 3 ways to get your patients to sleep study is 1, to own your own.
And what were those? Can you say the 2 that you use a little bit slower?
Yep. Braybon, BRAEBON, Metabyte Junior. And they do have an Elliott special if you mention my name. It's about $2,500 to buy, but every time you send it out, it's about $6 in disposables. And then we get a diagnosis, because dentists cannot diagnose. We get a diagnosis from a sleep physician in the cloud in the sky. And then for every appliance I make, another absolute that I have is that every appliance has some sort of healthcare provider that's basically approved it. Usually local, an MD, a DO, a PA, or a nurse practitioner. So that kind of covers you liability wise, even if the patient is paying cash. And that's kind of what I wanted to talk about at the end is all these dentists are so excited about it and take it back to their practice. And then it's just like one, hurdle after another in how to get around those and really create a program in your practice, not just, hey, we do appliances here and there. And so that was kind of where I was headed. So it was good to do a part 1, part 2.
Yeah.
I'll still send all the notes and stuff, but I saw a couple other things too here about someone's daughter that had a sleep study, and I would definitely look at doing a home sleep test because the sleep efficiency was so poor. She got 0 deep sleep, 0 REM sleep. It's really easy to not have sleep apnea if you're awake all the time. So when they're told that they're fine and they're symptomatic, that's where the detective work comes in. And it's all about not what the research says or what this, university says. To me, it's about the patient that's in the chair and their chief complaint and their pain right then and there and how we can help them. So getting the patient talking is the key to find out what's valuable to them and how we can help solve their problem. And we're able to help solve a lot of people's problems. It's very important for hygienists to become familiar with the signs. And that's what I was going to get to in the second part too, is what each person in the office, what I expect from them, what their assignment is. And for hygienists, it's really just to bring it up and get them to sign up for a consult. As simple as that. Their job is done after that. But most of my hygienists, interestingly enough, are tested and treated. So it makes it much more personal to them to bring up. So Sleeptest.com is the other option for home sleep test. It's a third party. Love the company. They do a telehealth visit. The sleep physician orders the sleep study, mails it to them. You get the letter of medical necessity, the diagnosis, the RX, everything. And they bill the patient's medical. You don't have to pay sleep test for service at all. So it's a good solution. Really a lot more details I wanted to get into about, again, what it's meant to me, to my patients, and how to think of it as a business in your practice and give it kind of as a startup almost, and having a key person in charge and giving them 6 months of freedom to make it happen. So lots of clues on which patients to talk to. You don't need to go to physicians' offices yet until you learn the workflow.
Hey, Erin, how much are you doing with kids?
We do now have a children's Airway program in my practice. And I was my own worst enemy with that because I was in the way. And one thing I've learned is things are much more successful when I get out of the way. And my hygienist took it over. She wanted more hours, but less physical, like over in the patient's mouth hours. And so she's taken that and run with it. She's kind of, Mondays are children's Airway and Botox, and she kind of leads that way. So I have a champion basically for everything in my practice that kind of is their wheelhouse specialty, brings them job satisfaction, and gets me out of the way.
Do you think a lot of these ADD problems that we see that are the physicians just diagnose and give them Ritalin, you think that's Airway can play a significant role in that?
Absolutely.
Yeah.
In fact, there's some ENTs that believe that ADHD doesn't even exist. And I just saw a study that showed that if pregnant women have sleep apnea, then there's increased chance of autism.
Oh, really?
Which I thought was interesting during their pregnancy. I do absolutely believe that all kids should be screened. And I had an in with the pediatricians around here for their study club. And then COVID happened. And so I'm still trying to get back in there to educate them that, you know, we really should be looking at that before medicating a child with speed.
Yeah. So let me ask another question, because this is something we struggled with in different aspects of dentistry is finding physicians that respect you as a dentist. And basically what I mean by that is they think, you know, I'm the physician, I'm the MD, I should be treating sleep, I should be treating airway. When a lot of them, you know, just want to give meds. Is there a good resource to find ENTs or pediatricians in your area? Are there groups? Again, this is not my expertise, I mentioned earlier. Are there groups or academies that are commingled dentists and MDs that have a website that I could punch in San Diego ENT that's a good guy, basically?
Not really. I would punch in dental sleep medicine San Diego, and they know who the ENTs are. Like, okay. I say I actually tell I have to coach patients, like, don't talk to your pediatrician. They're going to think I'm crazy. A lot of ENTs are like, let's watch and wait. I'm like, watch and wait them like suffer. What are we watching and waiting? And 70% in the study, the watch and wait patients ended up needing their tonsils out anyways. It's not all about tonsils. It's about growing and expanding their arches. We see 4 to 5 as kind of the sweet spot. And so we treat with, basically we did a healthy start was kind of our entry into pediatric airway. It's kind of like a whole program. And kids sleep with an appliance that helps build, has myofunctioning therapy built in, it has expansion built in, and it promotes nasal breathing. So sometimes we can get those tonsils and adenoids to shrink, but if not, we have an ENT that I've had to vet over the years that is a little bit more apt to jump in and take them out, where so many ENTs are like, no, well, they're fine. You know, they're conservative. But what I discovered is that a lot of tonsils and adenoids is like, it's like Dr. Hornbrook, if I were to refer you full mouth sealants, I don't think you'd be too happy with me. You'd be like, oh, we can watch and read these grooves.
Yeah, I'd give it to my hygienist, right?
Yeah. So to ENTs, that's what treating sleep out, treating tonsils and adenoids is for them. So they tend to shy away from doing it and being quote unquote conservative. So I just kind of find an ENT that gets the whole airway connection, and we've been able to help a lot of kids, which is cool.
Yeah, I bet. Are you doing any ortho in your practice?
Yeah, we do adult ortho, brackets and aligners.
But you don't do kids palatal expanders and...
Yeah, we'll do some palatal expanders when needed. We're kind of delving into that now because there's a whole kids airway program called ASAP. It's all online. It's a great resource to get into children's airway health as well as Healthy Start. That's kind of where we're headed, but that we also have some orthodontists that are listening to us for early intervention. Some that don't, but others that do. And I've been at this 13 years. And so not to say that it hasn't been easy, but I also like hitting the pavement and getting out there in the community and interacting with these people, with the physicians, and any in I have, I take.
Yeah, good. We talked about the weight deal. I think, I don't want you. So you mentioned the 2 sleep studies. Again, you and I talked about this before we even started. People kind of want to just use what you use because you're the expertise. Do you want to talk a little bit about some of the appliances that you recommend?
Yeah, so I the two sleep studies I do have is the Metabite Junior, like I mentioned, but also the WatchPat Pro. It's a little bit more expensive to send out. We do a cash fee for a home sleep test. We don't bother with medical insurance, but I use it for people that are coming from long distances. It's disposable. It's all cloud-based. So I have a few of those on hand if like I feel like the effort belt might not fit the patient because they're so large, then WatchPat Pro is good for that too. So it's good to have some options. As far as appliances go, really, I invest in good appliances because to me, my most valuable asset is my time and my team's time. And so if I make a cheap appliance, you're going to get cheap results. You'll get patients coming in with it broken all the time, frustration, leads back to the physicians. And so if you just make a good appliance from the beginning, you don't have to see as much on follow-up. And so my three labs that I use, I try to keep it simple, is essentially ProSomnus, Evo, and it's got a nice little flexible material. And then Panthera is a 3D printed nylon type material. It's indestructible. And then unfortunately, medical insurance has dictated to us which appliances we're allowed to use, many private and Medicare. And so I use a lot of Herbst appliances. So if the patient doesn't have enough teeth and I go to Somnomed, if they don't have enough posterior teeth, Somnomed's great in edentulous areas. So basically it's ProSomnus and Panthera. Unfortunately, I work with too many insurances that dictate to me. So I make the ProSomnus Herbst or the Somnomed Herbst based on how many teeth they have. So I had a kind of a cheat sheet or approach of how I do it when I approach a patient, but Evo and Panthera are my top two.
Okay, good.
In the contact info for all of those people too. So the 3 ways to get your patients a sleep study to get started is refer them out. Unfortunately, you won't see them for a while. The second is the third party, Sleeptest.com is wonderful. And they are so good and so on top of things and get you everything you need, especially if you're in New Jersey or Georgia. And then thirdly is owning your own home sleep test. So we send patients home with a cash fee that day from their consult.
Great. Good. Well, I think this isn't doing justice not seeing your slides along with this, so I hate to even get any deeper.